Haematemesis or vomiting blood. A 54-year-old male patient admitted to SAU with background history of alcoholism. So it's very important to focus on the stem before entering the room. So we have a patient with alcoholism and also had haematemesis. In examination, the patient is jaundiced and has ascites. He became confused after a second attack of haematemesis and low blood pressure and high heart rate. So while you're spending 1 minute to read a stem like this, so think about the main issues. So the main issues for this patient, one, patient is alcoholic, and that means they are at risk of alcohol withdrawal symptoms. Two, he had multiple haematemesis, and I'll be concerned about loss of large amount of blood and decreased blood pressure and entering into a hemorrhagic shock. There is also risk of aspiration, pneumonia, if they aspirated their own blood. They have jaundice and ascites as well. That means they are in decompensated liver disease, and we also have some concerns about this. So he had a second attack of haematemesis with low blood pressure and high heart rate. So I'm concerned about shock or hemorrhagic shock in particular. So when you enter, the first question that you can potentially be asked is, what are your concerns regarding this patient? So I would classify it in the same way. However, this needs to be prioritized a little bit. For instance, haematemesis is the most important for now. So I'll be concerned from a haematemesis point of view. The patient might have another attack, or he already had another attack of haematemesis with low blood pressure and high heart rate. That means they might enter in a shock or AKI. They might become hemodynamically unstable and require blood transfusion. And also, I'll be concerned about aspiration pneumonia if they inspire their own blood. And they are alcoholic, so we're concerned about alcohol withdrawal symptoms, and we need to start them on the chlordiazepoxide Paprenex. The last thing is they are ascetic and they have jaundice as well. So we're concerned about decompensated liver disease, and that will let us think of hepatic encephalopathy, spontaneous bacterial peritonitis for the ascites, and also the last thing is hepatorenal syndrome, and most importantly as well, the coagulopathy or the coagulation, deranged coagulation profile. So these are the main concerns that you should have in this patient. So we had the haematemesis and its concerns, having shock, AKI, aspiration pneumonia, and another attack of haematemesis, decompensated liver disease, hepatic encephalopathy, hepatorenal syndrome, and a spontaneous bacterial peritonitis, and alcoholic liver disease, or being alcoholic, the alcohol withdrawal symptoms, and we need to start them on Paprenex and thiamine as well. Okay, differential diagnosis in this patient. So you had a patient with an upper GI bleed. Okay, so we can have multiple reasons for an upper GI bleed. If this is the stomach, so you can have a few things really that can lead to upper GI bleed. So you can have some varices on the lower end of the esophagus. That's one of the main reasons, which is the commonest reason really. And also we can have peptic ulcer, whether it's a duodenal or gastric. So that's peptic ulcer, all right, or duodenal ulcer. We can also have something called, which is a cut in this area. It's called Mallory-Weiss syndrome or Borov syndrome, which is basically a rupture of the lower end of the esophagus as well, all right? You can also have cancer, might be a little bit bloody, and you can have the gastrointestinal stromal disease and angiodysplasia as well. But those four are the commonest causes for an upper GI bleed. How will you manage this patient? It's quite important to have a structure for the management of this patient, and also very important to think about the main concerns that you had early. So we had 3 concerns, and that was the alcohol, that was on the liver, and also haematemesis related. So since the patient had another attack with low blood pressure and high heart rate. So we're concerned about hemorrhagic uh, shock. So we need to manage this patient according to A to E approach. We need to mention that. I'll manage this patient according to A to E approach, making sure the airway is patent and secure, and the breathing. You're going to take an ABG and put a saturation probe and examine the chest of the patient for risk of pneumonia or having reduced their entry or choking, and potentially get a chest x-ray when the patient is stable, or if you're able to get as a portable chest x-ray to make sure there is no perforation, whether it's a Buraf syndrome or a perforated peptic ulcer disease. In the C, it's fundamental to put 2 wide pore cannula in the patient, the biggest one that you have, and also take urgent bloods. Most importantly, focusing on Groban screen and cross-match and coagulation profile. If the patient is actively bleeding, you might need to activate the massive hemorrhage protocol. The patient is actively bleeding and deranged consciousness and so on. So massive hemorrhage protocol needs to be activated immediately. Okay. Again, we're going to continue with the rest of the bloods for this patient. And continue with your examination, getting blood pressure and getting, all the rest of the examination, the pulse rate and so on. And measure the capillary refill time, central and peripheral as well. While you're waiting for blood to be transfused, you can start your patient in saline, normally NaCl, and obviously blood transfusion is needed after cross-matching. Okay. Also think about platelet transfusion. This patient is alcoholic and has liver disease, and they might have thrombocytopenia, but don't transfuse platelets until we have an evidence that platelets are low. So now we'll try to manage the patient supportively to compensate this hemorrhagic shock. However, we need to stop the bleeding as well. So we're going to talk about this in a little bit more detail. Well, stopping the bleeding from an upper GI bleed, we need to do endoscopy for 2 reasons. One is to identify the source of bleeding, and 2 is to stop this bleeding if we're able to. Okay. And if endoscopy is not available or the patient does not respond to endoscopy, we can insert a tube called Sangstaken Blackmore tube, which we will talk about it in detail as well. So that will be the management of the C and patient with upper GI hemorrhage. And then we're going to continue with the D. We can take capillary blood glucose for the patient and also do GCS score as well. And then E, examine the abdomen and see if it's peritonitic or not, and to the end of your A to E assessment. There are 2 more things, which I remember them by the 2 T's. We can give the patient tazocin and terlipressin, all right? So tazocin, for 2 reasons. Patient is at risk of aspiration pneumonia. So tazocin reminds me of antibiotic, all right? Risk of aspiration pneumonia, and terlipressin if it's evidence that the patient has varicocele that causes splanchnic vasoconstriction and reduce bleeding. So that was only the initial issue, which is the haematemesis. For the decompensated liver disease, we need to refer the patient to gastro to see if there is anything that we can offer to them. And for the alcohol withdrawal symptoms, start your patient on chlordiazepoxide Papernex. All right. So that will be your management plan or initial management plan for this patient. After we've done all of this, we need to escalate, and escalation will be to general surgery and gastro team for taking the patient to theater or to the endoscopy to get the OGD done for them. So going back, so we need to do active resuscitation, and that would be airway management, high flow oxygen, two-way per cannula, coagulation profile, and to the end. So I think in this particular scenario, you need to be quite sharp and short as well. I know it's a lot of things to mention, but I would say do an A to A approach, make sure the B is such and such, and then C, two-way per cannula, take bloods including coagulation screen, group and screen, coagulation screen, and cross matching, activate massive hemorrhage protocol if needed, and take the rest of the examination, stop the bleeding by endoscopy, and Sang stick and Blackmore tube if needed, and then complete the E and the D, and escalate, and Tazocin, and terlipressin, and the liver, and then alcohol as well. It shouldn't take more than a minute to mention all of this. Okay. Yeah, so I think we covered all of that. So control of bleeding, that would be endoscopy or banding, and tamponade, and also pharmacological measures that like vasopressin or erythroids, and urgent endoscopy as well for band ligation, and terlipressin or tazocin, and tazocin as well. Like I said, antibiotic and splanchnic vasoconstriction. The causes of thrombocytopenia in this patient, I mean, I think so. In this scenario, it would be appropriate to give you blood results that had the platelet blood results. Obviously, that doesn't mean it's happening, but could be. And the platelet count will be low. And the main reason the platelet count are low is that the alcohol is basically cytotoxic on the platelet itself and cytotoxic on the bone marrow for production of the platelets will lead to production, less production of the platelets. And also hyperesplenism. Patient might have DIC or hemodilution as well. Indication of platelet transfusion. It's one of two things, whether it's a platelet dysfunction or platelet consumption, all right, which means decrease on the number of the platelets or the function is affected. Function could be affected when the patient is on aspirin or clopidogrel or any other antiplatelet. Consumption could be an ITP and a DIC and maybe massive blood transfusion as well. And we talked about those before. However, our answer needs to be a little bit focused on the patient rather than the general indication for platelet transfusion. So here I would say ongoing coagulopathy in this patient due to liver disease or decompensated liver disease is the main reason. Okay, what are the blood findings that are just alcohol toxicity or ETOH? So basically, alcohol, like we said earlier, it affects the platelet count. So you have a patient with low platelet count, all right? And the other thing is macrocytic anemia. And the main reason why the patient get macrocytic anemia in alcohol is, if you remember from the basic histology and how the cell membrane is formed, so the cell membrane is formed by lipoproteins which are attached to each other in double layer, and these are usually lipophobic. And the alcohol is able to change the structure of these lipoprotein on the wall of the membrane and it will make it lipophilic. And the lipid will be able to pass inside the cell and the cell will consequently increase in size. That's why it's. So what are the sites of portal systemic anastomosis? So these are basically anastomosis between the portal system and the systemic venous system as well. So if we look here, so you have here, this is the portal vein. So we're going to have a few anastomosis. Number one, which is most important, is the lower end of the esophagus. Okay, the lower end of the esophagus, and the main one, and this is what is responsible for the varices, right? That's one. We also have at the lower end of the inner canal, that's the second most important thing. The upper end of the inner canal, between again the superior rectal vein and middle and inferior rectal vein. That's another site which can cause the hemorrhoids as well. The other thing is around the umbilicus, and that can cause the caput medusae. And finally, anastomosis of clonic veins, which, as you can see here, the superior mesenteric is going at the end to the portal vein as well. So these are the main sites for portal systemic anastomosis. I think lower esophagus, upper part of inner canal, and umbilicus are the main areas. And you can also mention the colonic veins as well. Which varices usually bleed? The most importantly at the lower end of the esophagus, pathogenesis of portal hypertension. So basically, what is portal hypertension? It is increased blood pressure in the portal venous system, and the main reason why, if you have liver, so portal venous system will go inside the liver, and then will be drained through the inferior vena cava. So what happens is, if you have like liver cell damage and regeneration by fibrosis, that will decrease the venous drainage through this area, and the blood pressure here will start to increase. All right. So basically, happens due to liver cell damage and fibrosis with nodular regeneration, resulting into cirrhosis, and this will obstruct the portal venous drainage and will cause hypertension. Are there any surgical options we can use for the patient to treat that? Yes, we can do something called portosystemic anastomosis or shunting. All right. So basically, we're shunting the blood from the portal system to bypass the liver to the systemic system again. And also, we can do stapled oesophageal transection for the gastric vein and short gastric veins as well, as you can see it here in this diagram. However, I think this is not happening nowadays. We covered before alcoholic liver disease in just 2 minutes. How is alcohol metabolized? So we talked about three main enzymes that are responsible for that. That's alcohol dehydrogenase and also catalase, and on the other side, aldehyde dehydrogenase. Our target is to convert ethanol into acetate on the other side. The alcohol can lead to fatty changes in the liver, and alcoholic hepatitis, chronic hepatitis, and cirrhosis, and then hepatocellular carcinoma as an end stage or a complication. Obviously, it can lead to decompensated liver disease, which we talked about it early, and this can lead to ascites with its complication, which could be dehydration, electrolyte imbalance, and also infections such as a spontaneous bacterial peritonitis, and finally like hepatorenal syndrome as well. Again, it can also cause jaundice and can cause, the platelet count to be less, which is thrombocytopenia, and coagulopathy and bleeding disorder. Mechanism of ascites. Ascites mainly happen due to creation of an oncotic pressure by hypoalbuminemia. So hypoalbuminemia will create, which is mainly produced by the liver, will create an oncotic pressure leading to production of large amounts of water basically into the peritoneal cavity. There is also retention of salt and water due to patient will have salt of third spacing, which is ascites, and they will be clinically dehydrated. Also, there is increased formation of hepatic and splanchnic lymph as well. All right, so this is basically chyle. What can cause confusion in this patient? So I will think if they had, aspiration pneumonia and evolved sepsis, that can cause confusion. 2, if they have hepatic encephalopathy due to decompensated liver disease or due to alcohol intoxication or alcohol withdrawal symptoms as well can lead to that. All right. Generally, shock, whether it's a septic shock or even hypovolemic shock, can lead to this. Patient has ascites, so we can think of electrolyte imbalance, specifically sodium and potassium, can lead to this as well. So we have many other causes for confusion in this patient, but I think the 2 clinically relevant to mention is alcohol intoxication and hepatic encephalopathy as well. B12 can cause macrocytic anemia. So till now, we would have mentioned 2 things that can cause macrocytic anemia, and this is alcohol and also B12 deficiency. We talked about alcohol that alter the cell membrane structure that make it lipophilic, and the lipid will move inside the cell, producing macrocytic anemia. But B12, it works a little bit differently. So it does work on the DNA synthesis. Well, basically, for any growth of any cell, we have 2 phases, all right? So we have the G phase, which is the growth phase. And at this phase, the cell will come from a smaller, a little bit bigger, a little bit bigger, and so on. But it cannot get bigger without, forever, because if this happened, the cell will be huge or very large and it will not function appropriately. So we need to have another phase to cut these cells into other cells, all right? And these are the mitosis phase or the M phase. So the DNA, the B12 works in the DNA synthesis, and if it's deficient, that will stop the cell at the growth phase without having to move to the M phase or the mitosis phase, and the cell will continue to grow without any kind of division, and it will lead to macrocytosis. All right, cool. So if you're thinking that this patient might need liver transplant, how do you explain this to the family? So first and foremost, when you're discussing, it's like discussing any procedure with the patient, but this one is quite serious. So I think I would say, first of all, I need to explain to the family when to get liver transplant and what would be the prerequisites for that, what is needed. So the prerequisites is initially to treat the current condition because the patient is presented acutely for bleeding. Number two, after treating the acute condition is and doing the blood transfusion, everything else, we need to consider stopping alcohol and discussing that the patient will need to stop alcohol for at least 6 months to 1 year before having liver transplant. Three, we need to make sure that the patient will be on a rehab program and will not go back to drinking again even after transplant, because that's the main reason of failure, and to make it really clear that this will lead to failure if they started drinking again. Three, I think, or maybe two, that's point number two, discussing the risks of this procedure. It needs to be explained that this is a major procedure with lots of complications as well. Most importantly, discussing the immunosuppression, uh, 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 the immunosuppression that the patient will be on for longer time, and that will lead to decreased immunity and might lead to infection as well in the patient. So counsel regarding the patient current condition, which is acute condition that needs treatment first, and the current treatment that can be offered, and the outcome of the liver transplant, and also the need to stop alcohol before having the liver transplant as well. So we mentioned early that to stop the bleeding, we need to do two things, or maybe initially one thing, which is the endoscope. And the endoscope is to basically diagnose and then to treat if it's something treatable. Okay. And if this has failed, or the patient is refractory, or the endoscope is not available, we can insert something called um, a Sanger-Steken Blackmore tube. And this tube basically has 3 ports and 2 balloons. So as you can see here, the small balloon is the gastric balloon, which goes beyond the lower esophageal sphincter, and then we inflate this balloon to cause compression on the lower and the uh, uh, upper part of the stomach, and will decrease the bleeding from the venous system. And this is the oesophageal balloon, and we can do the same with that. Will lead to compression on the venous system on the lower end of the esophagus. And also we have another port that is being used for suction from this area as well. Okay, so we have 3 ports. One is for inflation, one is for the esophagus, and one is for the gastric suction as well. All right. We also have some modification in something called Sanger-Steken Blackmore tube. Is a 3 lumen, and the other one is Minnesota tube, which is 4 lumens, and allows for aspiration not only from the gastric content but also from the esophageal content as well. All right. So the indication of this tube, like we mentioned, the patient did not respond to any medical therapy, and endoscopy is not available. I don't think that we do have to discuss how to insert it, but however, I'll leave this here. You can go through it in your own time. All right. So this is haematemesis in an alcoholic patient. We discussed the main issues, which is the haematemesis and being clinically shocked, and to the alcohol intoxication and the decompensated liver disease. We discussed the management is according to A to E approach, and don't forget the terlipressin, antazocin, endoscope, and Sanger-Steken tube as well if the treatment is refractory. We talked about how alcohol is metabolized. We talked briefly about the macrocytic anemia and the causes, which is alcohol, and what's its mechanism, and also B12 deficiency and what is its mechanism. We also discussed If this patient is confused, we have many reasons in mind, but the top two differentials are hepatic encephalopathy and alcohol intoxication. We're concerned about ascites in the view of decompensated liver disease and the risk of having a spontaneous bacterial peritonitis. And we explained the reasons for ascites, which is hypoalbuminemia and salt and water retention, and also increased formation of hepatic lymph or hepatic chyle. Thanks for watching.